Kaiser University Multidisciplinary Center would like to welcome Merceydes Morassi, presenting Major Depressive Disorders and Social Anxiety Disorders and Suicide, Part 3.
Thank you. So yeah, as Caesar said, this is part 3 of the webinar that we started last week. So far, we've already talked about some other diagnoses that are really common among children and adolescents. So we did ADHD, we talked a little bit about autism, we talked a little bit about eating disorders, and today we're going to cover these. We'll start with major depressive disorder. So for a major depressive episode, which I put MDD as the title, which would be major depressive disorder. In order to qualify for major depressive disorder, you have to have a major depressive episode. So the wording seems tricky, but really it's the same thing. So for a major depressive episode, we're looking at 5 of the following symptoms over a 2-week period. Depressed mood as per subjective or objective report. For kids, this could look like irritability as opposed to depressed mood. Anhedonia. Anhedonia is a very classic depression symptom, and it's kind of like just a lack of interest in things, or things don't really make you happy anymore. So it's like a muted mood state, we could say. Unintentional changes in weight or appetite, sleep disturbances. Now, those two are interesting because the typical presentation of depression looks like someone who eats less and sleeps less. The atypical presentation of depression would look like someone who sleeps more and eats more. And atypical depression is more common in adolescents and definitely more common in women. So something to keep in mind. Psychomotor agitation or retardation, what that means is that either they're like fidgety or they're slowed down. Tiredness or fatigue, inappropriate guilt or feelings of worthlessness, and impaired ability to think or concentrate, and of course, passive or active suicidal ideation. All right, this is a little table about like how the presentation might differ based upon the age of the person that we're evaluating. So I did also put that the rates of depression start to rise in adolescence. I think that's something to keep in mind. Yes, of course, depression can happen in young kids. It has happened, but we typically see the rates of depression start to spike really right around adolescence. So from age 3 to 5, a child might have trouble verbalizing their feelings. They might have a marked decrease in their interest in play. There might be self-destructive themes in play, which is interesting when you think about a 3 to 5-year-old and their imaginative play. If this play is all of a sudden starting to look destructive, there's negative things being said about the self, or imagine if they're playing like with dolls and one doll is like, say, them, and the other doll is, wreaking havoc on them. Something like that could be indicative that they're suffering with some type of perhaps stressor or perhaps depression. Thoughts of worthlessness or suicide. When they are aged 3 to 5, the symptoms do not need to be present for 2 weeks. They can be present for only a week. They can be present for a few days. We would intervene a lot sooner. We wouldn't have to worry about that 2-week threshold when we're looking at someone that young. From 6 to 8, the presentation of depression also looks like they have trouble verbalizing their feelings. There's increased somatic complaints. That's interesting too. So what that means is, like in psychology, we tend to say that someone is somaticizing, and that means they're taking a psychological issue, for example, depression, and it's manifesting in the form of a physical ailment. And so they could complain of neck aches or back aches. They could complain of some other thing being wrong with their body. Crying or shouting outbursts might be seen there, unexplained irritability, and observed anhedonia. So where the adults are watching them and noticing they're not interested in the things they used to be interested in. You pull out their favorite toy, put on their favorite cartoon, and it just doesn't seem to make them happy. From 9 to 12, the depression typically presents with low self-esteem, guilt, hopelessness, increased boredom, feelings of wanting to run away, and a fear of death. From 13 to 18, we see increased irritability, impulsivity, and behavior changes. We see decreased grades, poor school performance, increased disturbances in sleep and appetite. We see suicidality similar to adults, the increased likelihood of a chronic course of depression, and this one also has a stronger genetic association. The last two on there aren't really applicable in terms of identifying the issue, just kind of, I guess, things to keep in mind about what happens when someone is depressed at that age group. Sorry. Okay, let me move on. So I guess some ideas that the teachers could potentially apply in the classroom. Really, well, let me start with evidence-based practices. For us clinicians that are working with people who are actually depressed, the number one treatment modality of choice that's recommended by pretty much all the research is going to be CBT, or cognitive behavioral therapy. Cognitive behavioral therapy is particularly good because it addresses what they call the cognitive errors in the triad. And so this is well documented. It's been researched for decades, but cognitive psychologist Aaron Beck said that all depressed people have errors in the cognitive triad. And the cognitive triad is the self, the future, and like others or the environment. And so depressed people tend to think negatively about themselves, negatively about others, and negatively about the future. And so bringing that up and pointing it out here, you might say, well, what does that have to do with teachers in a classroom environment? Well, maybe you could, pay attention. Do you hear kids talking negatively about themselves, negatively about the future? We as adults can attempt to correct some of that thinking by maybe speaking positively about those things, or trying to find some sort of alternative perspective, that silver lining or the light at the end of the tunnel kind of thing. Sometimes it's just easier for an objective third party to be able to do that when the person themselves can't do that. All they're thinking of is negative. Also, teachers can provide empathy and compassion. So I think that's very important, that a kid could feel potentially like someone will listen to them, like someone understands them, and they can help the students identify positives in the triad, or exceptions to the rule. For example, no one will ever like me, everybody hates me. Well, we can help kind of point out, well, that's not true. Think about so-and-so who likes you, and just tone down those cognitive errors. Some statistics on suicide. Suicide is the second leading cause of death in 15 to 24-year-olds. And the majority of children and adolescents who attempt suicide have a significant mental health disorder, usually depression. Among younger children, suicide attempts are often impulsive. They may be associated with feelings of sadness, confusion, anger, or problems with attention and hyperactivity. Among teenagers, suicide attempts may be associated with feelings of stress, self-doubt, a pressure to succeed, financial uncertainty, disappointment, and loss. For some teens, suicide may appear to be a solution to their problems. Depression and suicidal feelings are treatable mental disorders. The child or adolescent needs to have his or her illness recognized and diagnosed and appropriately treated with a comprehensive treatment plan. Going back to the teenager bullet in there, it says that the suicide attempts may be associated with stress, self-doubt, etc. One thing I think is particularly noteworthy for teens is that themes of rejection and humiliation are big sources of stress for teenagers, as well as breakups, the breakup in romantic relationships, especially because as an adolescent, that's kind of their first experimentation with dating or attraction or whatever. And so when we look at things like instances of rejection and humiliation within a friend group or breakups romantically, those serve as really big stressors for teenagers, potential catalysts for depression, but also possibly risk factors for suicide. Some additional risk factors for suicide. Thoughts about suicide and suicide attempts are often associated with depression. So I will say this, as a clinician, we're not immediately alarmed if someone has passive ideas of death when they're depressed. That typically goes hand in hand. We become more alarmed the more detailed, the more frequently occurring this sort of thing happens. But we definitely pay attention when someone says that they're thinking about death or suicide in any way. Obviously, now we've got full clinician radar zoomed in on this client, what is going on? But in addition, we want to know some other risk factors that might make somebody more likely to go ahead and follow through with this type of idea. One would be, it says family history, but personal history and family history. If someone themselves has a history of suicide attempts, they're at a much higher risk of trying again. If there's a family history of suicide attempts, that would make the child or adolescent more likely to attempt as well. Exposure to violence. This could be domestic violence. This could be maybe the kid is living in an unsafe neighborhood and they just see kind of, community violence throughout. Impulsivity is a big factor in suicide. As many of us know, your brain isn't even fully developed until your mid-20s, and the frontal part of your brain that is responsible for controlling our impulses, that's one of the last things to develop. And so that probably has something to do with why we would see higher rates, I should say, spiking around adolescence or early adulthood, is that ability to regulate that impulse isn't even fully formed yet. Aggressive or disruptive behavior could potentially be a risk factor. Access to firearms is a risk factor. Bullying, as I said before, huge catalyst for somebody who is an adolescent, a huge catalyst for depression, a big risk factor in suicide. Bullying is very, very, it's very detrimental. Obviously, some adults will use that term as well. Like, it's not impossible for an adult to be bullied. But when I think of bullying, I really think of adolescence, because when it happens at that age, it leaves a lasting mark, as we're going to talk about with social anxiety disorder, which is also in this presentation. Feelings of hopelessness or helplessness. And then the last one is acute loss or rejection. Additional risks, alcohol. Yes, alcohol is involved in as many as half of all suicides. So these older kids, if we're looking maybe high school years, it would be naive to think that adolescents in high school, some at least, are not experimenting with alcohol. That does happen. And so when there is experimentation with alcohol, which is more common when we see, it's more common in boys, and it's more common in boys that play particular sports, for example, like wrestling or football. Those tend to be sports associated with drinking. But we need to keep in mind that alcohol can fuel suicide. If you have a depressed teenager who's also potentially hanging out with a party crowd or experimenting with alcohol, this is a really bad recipe. Antidepressants are also a risk factor for suicide. Believe it or not, it seems almost counterintuitive to say this, but antidepressants for teenagers in particular do increase their risk of suicide in the initial phases that they're taking the medication. So the first few weeks are particularly dangerous for adolescents. And those are SSRI drugs. So, like, for example, Prozac, something like that. Diagnoses such as PTSD and borderline personality disorder. A lot of clinicians hold off on a borderline personality disorder for a teenager because personality disorders are pretty severe, and we tend to we want to see the chronicity of them before diagnosing. But it's possible. It's possible that a teenager could have a borderline diagnosis. It's definitely possible for a child or an adolescent to have encountered a trauma so severe that they received a PTSD diagnosis. Both of those diagnoses increase this person's risk factor of suicide exponentially. So we really got to keep those in mind as well. For clinicians, we tend to distinguish between active and passive suicidal ideation. We believe that the more detailed the plan, the more likely it will be carried out. So that's a big factor for us as a clinician. We ask a ton of questions regarding what are these thoughts? Are they passive? For example, a passive thought could be something like, what if I just didn't wake up tomorrow? Would the world be better? Versus somebody who's actually thinking about how they would carry this out, who would find them, what time of day. Once you start getting into details, then we start getting nervous as clinicians, because that means, okay, this person is really putting heavy thought and consideration into this. Some warning signs for suicide. These are, I think, are a little bit kind of easier for the adults in this child's life to potentially notice. Some of the other risk factors we talked about, would include family history. It might include certain feelings that you don't have access to. But a lot of these warning signs here, we can see as adults. And so if they can draw our attention, we can potentially alert the right people and maybe get this person some help. So one big warning sign would be a physical change in their appearance or hygiene. Honestly, this could be indicative of depression as well. But it is something that if you see all of a sudden a kid who usually comes in well dressed, he usually comes in looking groomed, all of a sudden kind of looks disheveled, maybe dirty, that should draw your attention. An increase in alcohol or drug use, as I mentioned, alcohol being a big factor associated with suicide. If you're able to see this, which you might not because you're seeing them in school and who knows what they're doing when they're not in school. But if you're able to see maybe these kids hanging out more with the partying crowd or seemingly looking like they might be experimenting with drugs or alcohol, know that that is a real warning sign. Sudden drops in grades, that's something we can notice. Social withdrawal, so pay attention. Are they moving away from friends? Are they kind of isolating? Talking about suicide or a preoccupation with death. And so this makes me think of when it comes to like little kids who are potentially thinking about suicide. If you think about like maybe some movies, and I hate to reference movies because they're usually so wrong, but some movies will sometimes portray kids drawing pictures of death, somewhat morbid type pictures. Maybe that's indicative of what this child is thinking about. Or maybe the kid is exposed to too many horror movies at home. I don't know, but it would draw my attention for sure if I saw a little kid drawing images of death or images of some type of suffering, something like that. Risky or reckless behavior, such as reckless driving or unsafe sex. This kind of ties into like a hopelessness thing or kind of an apathy, like who cares? What's the point anyway? Self-harm behavior such as cutting. And I will say not all cutting equals suicide. There are people who cut or self-injurious behavior. But when we say cutting, a lot of times what we think of is someone, potentially maybe cutting their wrists. There is usually blood involved. Sometimes it's a deep cut. Sometimes it's kind of more surface level, whatever. The idea is that can sometimes happen with no intent for suicide, with no intent for death. It could be a way of emotional relief. It could be a manipulation strategy. There's a lot of things it could be, but regardless, when we do see something like that, it does indicate some sort of pathology, and it could be a warning sign for suicide. It could be maybe the first initial cut is somewhat superficial, and then from there it escalates. So self-harm behaviors such as cutting do need to draw our attention. If they're talking about feeling hopeless or having nothing to live for, that can be an indicator. And then researching suicide methods and or acquiring weapons. And so if you were able to check browser history and see something like that, that should be a really big warning sign there. Anyone who's taking the time to research how to do this, how to essentially execute their plan, they're getting more and more serious about the plan. Okay, so what can we do? We can honestly express our concern, even to the student, like, I'm worried about you, and this is why. I think a lot of people are afraid that if they say something, even directly call out behavior or directly ask questions like, are you thinking of hurting yourself? And, there's a fear that you're going to plant the seed. Like, oh, I don't want to say that because then I'm going to give them the idea. I get where that fear is coming from, but it's kind of an irrational fear. Like, ask questions, let people know that you care. Most likely you're not planting any seed. Also listen with empathy. And so we're not always the best listeners. But you got to, in this case, try to be, try to listen, not to necessarily solve a problem, but just so that this person feels like they're understood, like they're supported, like their feelings are validated. When it comes to a person who is in crisis, and so obviously being suicidal is a crisis, all of us counselors kind of drop our usual go-to strategies and go into listening, empathy, validation mode. And so myself included, I'm a strict behaviorist. Most of the time when I'm working with clients, I'm like, where's the problem? Let's fix it. Here's a solution, X, Y, and Z. I can't even do that here. It just, that goes out the door and it's just straight. Let me listen to you so that you know someone gets you. Help them maintain relationships. As I mentioned with the risk factors, social withdrawal and isolation is a risk factor. It's something we see in depressed kids. It's something we see in people who are potentially thinking about suicide. Trying to reconnect them with their relationships is a huge benefit to them. I think there's a statistic indicating something along the lines of like, you have an 80% increased risk of depression if you live alone. That in itself shows our need for social support, our need for others. And so if we can help kids maintain their friendships, or potentially help them create new relationships, if there is some sort of breakup in a friend group, that happens constantly, especially in adolescence. You know, so-and-so is not friends anymore. So-and-so doesn't like this one and they can't hang out with them. We can help them strengthen any relationships they might have or potentially help them create new ones. Trust your gut. We do have an intuition for a reason. As adults, we've experienced a lot more life. We know kind of what is what. And so if you're evaluating this kid and your gut is just saying, no, something's not right here, then don't be afraid. Don't be afraid to follow your gut and report it whenever you need to report it. Maybe to that, well, maybe that's to a superior of yours, a supervisor of yours. I don't know, but trust your gut. Prioritize safety. That's something I think that, you know, we would hope that parents are doing for these kids at the home. A lot of schools already have safety precautions in place, but something that you would want to keep in the forefront of your mind. And then there's the suicide crisis line, which is available via text or chat. If you go online and you look it up, or you can even call 988, and you literally just 988 call and you're going to be connected to a suicide crisis line. So that's good information to have, especially for a teenager who might be thinking about it. Just giving them that number could be really beneficial. So I'm going to talk a little bit about copycat suicides. I find this to be a very interesting, the study of copycat suicides, but it's also very alarming in the sense that media, in a lot of ways, perpetuates something like suicide. So there are studies that look at suicide, and there's increases in suicide in the 9 days that are following a highly publicized suicide. And so studies confirm there is a relationship between suicides and media coverage. And so the more media coverage for a suicide, the more likely there are going to be additional kind of copycat suicides following it. Clusters of suicides seem prevalent among teens. Teenagers are especially kind of responsive to this idea of copycat suicide. Yes, it's a phenomenon that can happen among adults as well, but because teenagers are so socially driven and so influenced by peer behaviors, well, in this case, modeled behavior, right? So that's a modeled behavior becomes especially important to look at when we're talking about teenagers. 5%, they estimate this, and I mean, this could be higher. It's kind of difficult to actually gather a concrete, solid statistic on something like suicide, because we obviously can't ask the person themselves for this information. So a lot of these they're obviously just estimates. We're doing the best we can to put numbers to it, but the estimate is that maybe 5% of all teenage suicides could be a result of imitation. It seems like a low number, but still, the fact that even 5% are the result of just copying the behavior of someone else is kind of alarming in itself. Why? Why would anyone copy suicide, you might say? Well, it's romanticized in the media. When the media covers suicide, there's always, you know, the pictures of the person who committed suicide. There's always people talking about how wonderful they are. This person kind of gets this moment of glory on the TV, on the news, whatever, where everyone's sharing how much they love them, how much they care about them, and showing them in their best pictures. It's romanticized, this idea of this person. No one's there talking about how they struggled or what their bad traits were, or the damage that they've inflicted on their family and friends in engaging in this behavior. Instead, they're just talking about how much they miss them. And so there's potentially teenagers sitting somewhere in their living room watching this thinking, oh, if this were me, if I committed suicide, people would remember me like this. People would cry about me. I would be important. And so the way that we talk about suicide on the media in itself is a way that romanticizes it and almost makes it more attractive to any kind of depressed teenager who might be thinking along those lines. The person also becomes a martyr. It's usually an attractive younger person, and they list, as I said, all the positive aspects. They talk about, you know, for example, oh, Johnny was on his way to a football scholarship, and his friends say he was always the life of the party and so social. And so again, they romanticize the idea of suicide. They romanticize this person. This person is kind of put on a pedestal. The media also describes the measures used in detail. So they'll talk about how they committed suicide, where it was, perhaps if the person used a weapon, or if they maybe overdosed, whatever the method of suicide was. The media generally explains this with enough detail that it essentially provides kind of like a working guide. Again, some depressed kid sitting there watching this can take notes basically and say to themselves, okay, well, this is obviously what I need to do if I want to succeed in effectively ending my life. There's very little reported about failed attempts and the horrible aftermath. For example, I remember I saw a news article once of a woman who attempted suicide by gun. She shot herself in the head and took off part of her face. That's what we need to see on the media all the time, because that would be basically a warning to anyone considering, look, here's somebody who attempted, they lived through it and have permanently disfigured their face, permanently disfigured and physically crippled their body. The media doesn't talk about that. And so they only talk about the successful completion of suicide in a romanticized way. So if we had more of these failed attempts, or these attempts that lead to severe catastrophic outcomes, perhaps we would be able to, like, what's the word I'm looking for? I guess, you know, there's a word here, but we would be able to maybe, I guess, have kids rethink this idea. Is this even, that's the word, deter. It would be a potential deterrent to the idea of following through or copying something like this. And then obviously when the media is talking about a suicide and reporting on it, they don't say anything about how this doesn't actually solve anyone's problems. No problems are solved via suicide. Instead, there's a new host of problems for the family and the survivors of the person who has committed. And that's not something that's really discussed either. So that's potentially why suicides are copied in the first place. Now, social anxiety disorder. Social anxiety disorder is a relatively common diagnosis. It is highest in terms of prevalence in late adolescence and early adulthood. The current DSM definition is this. It is a persistent fear of one or more social or performance situations in which the person is exposed to unfamiliar people or to possible scrutiny by others. The individual fears that he or she will act in a way or show anxiety symptoms that will be embarrassing and humiliating. So a lot of times, one of the situations that is most feared for someone with social anxiety disorder would be something like a presentation in the front of class. Sometimes eating in front of people is a very highly feared situation. So stuff like that could meet that criteria A. B, exposure to the feared situation almost invariably provokes anxiety, which may take the form of a situationally bound or situationally predisposed panic attack. So panic attacks can happen as well. This idea that, no, you got to get up there, you got to go present in front of class, it can lead to a panic attack. And that's not saying, I'm not saying here, oh, then we should never have them present in front of class. I'm not saying that that's the recommended go-to either. But keep in mind that for somebody with social anxiety disorder, the idea of having to go ahead and be in front of public, presenting something or saying something, or at least in some way exposing themselves to possible scrutiny, can be enough of an anxiety provoker that it leads to actual panic symptoms. And if you guys aren't familiar with panic attacks, which I would hope that you're not, because they're awful, really, truly. You feel like you're dying. When you have a panic attack, it kind of feels like a heart attack. You feel like you can't breathe, your heart is racing. Most people who have a panic attack end up in the ER because they literally think that they're dying. And so that's, quite a price to pay for being anxious about a social situation, that you go get yourself so worked up that you think that you're having a literal heart attack. Criteria C, the person recognizes that the fear is unreasonable or excessive. Criteria D, the feared situations are avoided or else are endured with intense anxiety and distress. And criteria E, the avoidance, anxious anticipation, or distress in the feared social or performance situation interferes significantly with the person's normal routine, their occupational functioning or academic functioning, or their social activities or relationships, or there is marked distress about having the phobia itself. That impairment in functioning is something we have to see with every disorder, which we talked about in the first webinar if you were there. If there is no impairment in functioning, there's no disorder. But for social anxiety, there usually is an impairment in functioning. I teach at the college level, but I've had students come up to me and say, like, Miss, you don't understand. I can't do this presentation. I don't care. I don't care if you fail me. I'm not going to do it. And so if you're willing to take an F for the semester, instead of going up front of the class and presenting in front of your peers, you might say that that is impairing your functioning, because now academically your grades are going to drop. Your potential career goals are being affected because this fear is so overwhelming. So behavioral causes, humiliation and bullying lead to avoidance patterns. So this is, when we're looking at something like social anxiety, it's explained best through behaviorism. It's treated best through behaviorism. Usually 90 some odd % of people that are diagnosed with social anxiety disorder will report an episode or maybe multiple episodes of bullying and humiliation that occurred during their adolescent years. And so what happens is when someone is bullied or humiliated, that is such a painful experience that they start avoiding any experience or situation that is somewhat reminiscent of that. Okay, so like, oh, there's a bunch of, my peers over there, but I don't know them and I don't know what they think about me. And so I'm just going to avoid that because it's too anxiety provoking to think that if I go over there, they might reject me. I just can't handle being rejected again. And so this starts to lead to a pattern of avoiding all kinds of things because it makes them feel better. If I just don't go and talk to them, if I just don't do these new things, I don't have to worry about anxiety. I don't have to worry about being rejected. And so that feels a lot better. The teacher could potentially use a Confederate student to aid with exposure exercises. And when I say a Confederate student, this is like a undercover teacher's helper. We don't want the other students to know that this student is essentially working for us, but this is probably one of your, like a pro-social, very ideal student that models good behavior, that is, well received and liked among their peers, a kind student. If we can get them to kind of help us out where we have these kind of socially anxious kids possibly talking or presenting in class, and we have Confederate students that are able to provide encouragement and reinforcement, and it's coming from a peer, maybe that can mitigate some of the negative effects that this other person has experienced when they were rejected or bullied or potentially felt anxious in another situation. So think about it. If you have some really, like I said, pro-social model students, maybe you could say like, hey, do you want to do me a favor and try to be extra supportive or validating when so-and-so presents their thing this week. That could be really helpful. Reinforce students who engage in pro-social behavior with peers. Why is this helpful? Well, it might not even be the student in question. So let's say our anxious student is Johnny, right? And this is saying just reinforce students who engage in pro-social behavior with kids or with their peers. If Johnny and all the other kids who bullied him observe me, the teacher, constantly providing reinforcement in the form of praise, or maybe special privileges, or maybe some sort of prize from the prize box, whatever it may be, to the students that are, you know, treating each other kindly and respectfully and getting along well, then it kind of sets the stage for everybody in the room that, like, this is the type of behavior that is accepted. This is the type of behavior that gets rewards. And a lot of times the other kids will start to follow suit because they want those rewards as well. And so you can kind of just change the climate of the classroom by doing that. You can also help identify other kids with similar situations so as to create a feeling of universality. That's one big thing that really does help us as people, is to know that, like, our suffering is not alone. You know that phrase, misery loves company? That's kind of a negative way to put it, but when you are hurt, you know, it does feel a little bit better to know someone else has been hurt the same way you have, because you know they get you. It's like, okay, it's not just me. Other people have experienced the same kind of pain or the same kind of situation. And so if you identify one student who's very socially anxious, or one student who has been through some sort of humiliation scenario with their peers, and you could potentially group them with another student who has had a shared similar experience, maybe there's some commonality there. Maybe there's a way that they can almost form a bond because they have some mutual understanding of what it's like to be that person. I wrote here, do not dispute a kid's feeling that he is being targeted for his minority status. The belief system is actually protective. So this means when we see kids that are being bullied that are part of a minority, whether this is an ethnic minority or some other minority status, if the kid says, you know, for example, so-and-so bullied me because I'm Black, you don't want to negate that and say, no, that's not why. It has nothing to do with your race. It has nothing to do with your ethnicity. We don't want to say that. In reality, what's like the studies show is that if a kid can attribute the bullying to something like race or ethnicity, that makes them feel a little bit better, because it's not being, okay, let me back it up, right? If I'm being bullied and I can't attribute it to my race or ethnicity, it's because somebody doesn't like me, the person. Something is wrong with me. I'm flawed. Whereas if a child is able to say, they don't like me because I am this race or this ethnicity, it makes it less personal. And now almost they can look at this bully and think to themselves, well, this bully is obviously, you know, this bully is a flawed person. This bully is judgmental. They're racist. They're whatever. And so there's a way to externalize that bullying that has happened without the kid feeling like there's something internally wrong with me. So we don't negate that. If that's what they're saying and that's the reason why they think they're being bullied, leave that alone. Just validate it and make sure that they know that you, the adult, support them and are there for them to listen to them if they want to talk about what has happened with these peers. All right, so is it an emotional or a behavioral problem? That's a good question that we don't always know the answer to. A couple things that we like to take a look at is behavioral contrast, and that's a behaviorist term. So behavioral contrast means that sometimes when a behavior is increasing in one like setting, like for example, school, we'll use the school environment. If a behavior is increasing in school and decreasing at home, that would be behavioral contrast. When you see the behavior doing different things in different settings, usually that's indicative that there's something going on with the setting. Not always, but it's pretty much most of the time we'll say, okay, so you're saying that he does a lot of this at school, but never at home. All right, we need to evaluate the environment at school. So if there is behavioral contrast, it more or less is likely to be a behavioral problem, something relative to the environment. Because if a kid is struggling with depression, you're going to see that depression. You're going to see it in a school environment, in a home environment, with their friends, on the weekends. You'll see it. It will follow them because it's this mood disorder, this depression or whatever is living within them. So paying attention to where the behaviors are occurring, and if it's kind of consistent or inconsistent is a good indicator. And then I said antecedents, really trying to pay attention to what are the factors that trigger this behavioral response? Like, for example, does this kid act fine all day, and then as soon as you send them out to recess with their peers, they come back in looking deflated and sad? In that case, access to recess or time with peers could be the antecedent that triggers these depressed feelings. A lot of times we don't know, and you're busy. So how are you supposed to pay attention to how everyone feels at any given point of the day? What I like to do there would be a scatter plot. And so a scatter plot, you're basically like, think about like a matrix or like a table with a bunch of columns and rows. Do the days of the week at the top and do the hours of the day along the side, and then kind of just start notating when you see things happening. So for example, if I have a scatter plot in front of me, today is, I don't even know what today is. Today's Thursday, it's 9:46. If I look up and I see at 9:46, Johnny's all of a sudden sad, I'll find Thursday, 9 o'clock, Johnny's sad, maybe make a note as to what the activity is that we're doing, and just start taking little notes about the time of day, what else is going on around them. Are you guys doing certain activities? Are there certain peers present? Maybe you get a better picture of what we call the antecedents or the triggers for certain behaviors. Onset and trend, that's something we also like to look at. Is it a clear sudden onset, or is it gradually getting worse? For example, you have a star student, always on time, always does their work, always comes in prepared, dressed well, well-groomed, and then one day comes in, forgets the backpack, looks completely disheveled, has their head down on their desk the entire day. Well, that's a pretty clear and sudden onset. Something has happened here, right? Like this, it's almost like a different kid came in the next day. Okay, that's a sudden onset. Something's obviously going on. Those are clear indicators. Unfortunately, it's not always that easy. Like sometimes kids don't have this clear sudden onset. It's just one day you think to yourself, you know what? This kid hasn't been the same in a while. It's been a couple weeks since I've seen them do X, Y, and Z, or they've been a little bit more distant lately. And so when you have this kind of gradual onset, it's a little more obvious as to when it started and what it actually is. And obviously, when you're dealing with multiple students, 20, 30 students at a time, it would be very hard for you to notice the gradual onset of something like this among many different students that could potentially all be going through something at the same time. Okay, changes. Paying attention to their changes in their life, in their home, in their friendship circle. Are these circumstantial? Are these transitional changes? Did they move to a new house or to a new neighborhood? That creates some stress. And so maybe some of what you're seeing is a response to the new stress of moving. Did something happen in the friend group? Okay, potentially they're responding to something in the friend group. That's not uncommon that adolescents feel depressed, maybe not clinically depressed to the point of major depressive disorder, but that adolescents would feel some sort of depression when there is like turmoil among their friendship groups. Yeah, that's really stressful for an adolescent. And then we want to pay attention to if we can attribute it to some sort of transitional time period or a life stressor, or is this potentially something a lot more serious? Okay, and these are the references. And now I have time for a little Q&A. If anybody has questions for me, I am happy to take them. Okay, I don't see any questions popping up, but then again, I can't get to my chat box, so that's a problem. Will you guys let me know if there's any questions? I don't think there is.
I don't see any coming in.
Okay, well then, I guess that's it for the day. Thank you, everybody, for joining us.